Good evening, delegates. Good evening, doctor. Good evening, faculty member. It's my privilege to welcome you for this wonderful series, Trending Ask series, which is so let's start with this. Is D, which will cover the topic Dilemmas in Diabetes in Pregnancy and DIC. So before we start with the series, let me show the short introductory video on DG. And with that, let me start the episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
So I'm happy to introduce the master of ceremony for episode D, Dr. Munjal Pandya and Dr. Pousali Sanyal. So let me introduce Dr. Munjal Pandya. Sir is Associate Professor at Narendra Modi Medical College in Ahmedabad, Gujarat. Sir is Honorary Secretary of Ahmedabad Obstetric and Gynecological Society for the year 21-22. Sir has published many papers and chapters and winner of Dr. Kamini Rao West Zone U of Oxy Oration for year 2021 and authorized Gujarat photo book self-published in September 2022. And let me introduce Dr. Pousali Sanyal, ma'am. Ma'am is a consultant at Woodlands Hospital, Bellevue Clinic, Amrit Dhakuria, RSV Hospital. Ma'am has published over 20 papers in nationals and international journals. So I welcome both the MOCs for welcome Dr. Niranjan Chavan and Dr. Komal Chavan. Thank you, everyone.
Thank you so much, sir, for your kind words of introduction. Dr. Sanyal, would you introduce Dr. Niranjan sir first, ma'am? Can we have the CV slide, please?
Can we have the CV slides? So our convener is Dr. Komal Niranjan Chavan, ma'am, a very dynamic gynecologist. She has been organizing this task series. Ma'am is the medical director of the Chavan Maternity and Nursing Home. She's a senior consultant, DNB teacher, and unit chief of DN Desai Hospital, Mumbai. She's a chairperson. She's been the chairperson of Foxy Medical Disorders in Pregnancy Committee from 2019 to 2022. She's been the zonal coordinator of Foxy from 2022, and she's currently there. She's a chairperson of AMOGS Family Welfare and MTP Committee from 22 to 2024. Ma'am is member of Managing Council of MOGS, Joint Secretary of ISOPAP Mumbai chapter, and she has been the national expert for Foxy UNICEF Lakshya project. Ma'am is the national trainer for Foxy Dhira and RAC project, and she has won many awards like the Foxy Mr. N.A. Pandit and Mrs. Shailaja Pandit Women Empowerment Award in 2022, the Foxy Dhira Award in 2022, the Foxy Dr. Meheru Dara Hansotia Best Committee Prize in 2021, and Foxy Appreciation Award for Valuable Service as Chairperson in 2022. So, ma'am, we welcome you.
Mr. Nishant, can we have the CV slide of Dr. Niranjan Chavan, sir, please? It is an honor to introduce Dr. Niranjan Chavan, sir. Actually, sir has been a person who has been jolly as well as at the same time encouraging the juniors all the times, just like ma'am. We have been fortunate to work under sir as well as madam, and we have fond memories and a learning process with them. To introduce formally, he has been the honorary treasurer of Foxy 21-24 tenure, president of MOGS for 22-23 year. member Oncology Committee of SAFOG for the tenure 21-23, Joint Secretary of AFG 22-23, Dean AGOG and Chief Content Director,
Thank you.
High Card
Thank
and
you,
famous.
Munjal.
Yes,
Thank you.
yes, sir. We are eager to listen to you and ma'am, sir. And we wish that just like us, many more juniors would keep on learning from both of you. Thank you so much, sir.
Thank you so much, Munjal, and I welcome you all to this episode D of a task series that is trending Ask the Expert series, and D stands for dilemma, and we always have a dilemma when there is a diabetes or we have some dreadful complication like a DIC, and that was the idea behind this D episode. And learning in a chronological order or something, it makes little fun. It makes a little more receptive to us, and that was the idea behind this task series. And this is brought to you by the AGOG, and you have seen the video of AGOG, and we also have the journal, Global Journal of Academia of Gynecologists, and in here we can publish the articles of our eminent speakers as an article. And this is established way back in 2019 with Dr. C.N. Purandare sir, and it is an ongoing journal process. And this is the task series second season going on. We earlier had our seasons and a lot of eminent speakers previously, and this is the second season wherein we are going to have the episodes from in A to Z series. And today I'm really honored and to have the presence of none other than Dr. Hema Divakar as the chief guest. I welcome her, and Dr. Ragini Agarwal as the guest of honor. We have all the eminent speakers, our coordinators. Dr. Munjal Pandya has done a fabulous job, along with all the participants from various zones. We have Dr. Kavita Singh, Dr. Manoj, Chellani, Dr. Charmila, Dr. Supriya Jaiswal, Dr. Jayshrijena Kapadia, Dr. Pushpa Junghare, Dr. Manju Puri, who will be the expert on the panel, Dr. Shakuntala Kumar, Dr. Poonam Goyal, Dr. Sanjib Dutta, Dr. Indranil Dutta, Dr. D Geetha, and Dr. Soumini. They all have been really active, and I'm really eager to have interactions with you. Now, may I have a CV of Dr. Hema Divakar, madam? I know Hema Divakar, madam, really very closely, and she is most inspiring person I know in Foxy. Always very active, plus very, you really feel so encouraging all the time to everybody. Can I have madam's formal CV? And she has been the president of Foxy, and then she is also very active at the FICO level. Nishant?
Yes, ma'am.
Yeah, I want madam's CV. Dr.
Yes,
Hema.
yes.
Yeah. So madam has been so active at FIGO level. We know currently she is the chair of the Well Women Care at FIGO. She was earlier the chair of the FIGO ex-chair of the FIGO PNCD committee. She's also the president of the DIC and the dean of Karnataka College of Obstetrics and Gynac, CEO and chairman of the artist for her, the logo which we can see behind madam, and also the medical director at Divakar Specialty Clinic and a senior consultant. She has always made us proud at various levels, be it Manyata or be it, getting awards like the FIGO Women Achiever Awards or the Global Asian Award, CME Excellence Award, and so many awards to her credit. So I welcome Hema Divakar, madam, and I request madam to address the audience.
Namaskar. The convener, Dr. Komal Chavan, and the co-convener, Dr. Niranjan Chavan. If you ask who is the most trending couple in Foxy, the choice is obvious. It has to be the Chavans, indeed, who are hosting this brilliant series. And I very fondly hope that the asks in the leadership position will be offered to you by the voters in Foxy and the Almighty's grace, and you will continue to excel. The sweet connections, as we call the D for diabetes, is the trending topic because it's always shrouded with confusions, and we always try to bring in some clarity, and then each one in their own pockets is doing their own little things, and it's been a very tough subject. Ragini is a guest of honor, and she is a leader in the cosmetology field, and the laser therapy, etc. How is diabetes and cosmetology connected? If you ask, like how the Hema Divakar and Ragini are connected, it is all about the insulin resistance, the PCOS, the variety of obesity, acne, and other factors which need some cosmetic therapy as well. So we are all, it's like global, means it's all connected, integrated. So it is such a fine combination of the speakers, very distinguished from all across the country. And I'm very sure that this will go global very, very soon. And we will have distinguished speakers to exchange their ideas and their experiences across the globe. And may I wish not only the delegates in today's meeting, but also all the leaders and members today led by the next generation, Munjal and Pousali. May many of you join the force to do our very best for the girls and women in our own big country, and let our voices from the low middle income countries be heard loud and clear that we are second to none. So whatever is possible, whenever it's possible, however it's possible, and whatever it takes, we promise to do our best, just as the tasks are cut out. We have stepped back into the position of thought leaders and the taskmasters for the day, as you can see. Komal and Niranjan, wish you all the very best for all times. Thank you for having me here as the chief guest, but I always feel a part of this whole family of friends and colleagues. So I would rather be with each one of you than in a different distinguished position of the guest. So I'm very willing to be of any support for translating knowledge into action, because thoughts can be many, but a single step in implementation is a key to the success of any health initiative that we take in our country. Namaste and thank you again.
Thank you, madam.
Thank you. Thank you so much, madam, for your pearls of wisdom. And now may I have CV of Dr. Ragini Agarwal, madam? Yeah. Dr. Ragini Agarwal, madam, we all know her. She has been the past vice president of FOXI, and also the consultant obstetrician and gynecologist from the city of Gurgaon, having 35 years of experience in treating high-risk pregnancy, director of medical services for W. Pratiksha Hospital, Women's Hospital, and clinical director of obstetrics, gynecology, minimally access surgery, and cosmetic gynecology, which she has her expertise in it. She has so many firsts to her credit. As a first gynec endoscopist of Haryana in the private sector, first gynecologist to do operative laparoscopy like hysterectomy in Gurgaon way back in 1998. And also she introduced the aesthetic gynecology and laser to North India. And really I can see her, she's the queen of North India. And we are so fortunate to have Dr. Ragini Agarwal as our guest of honor. So I welcome her and ask her to address the audience.
Thank you, Komal, for your kind words. Very good evening to all of you who are here in this wonderful DDDDD episode D, Dilemma, Diabetes and DIC. And it's honor to be here and sharing dais with none other than Dr. Hema Divakar, another D. And Madam is really considered a master in diabetes. And very truly, she has said the couple, Komal and Niranjan. Yes. Every single word is very true about them. And coming to the topic, they are very, very essential. The diabetes, which is now called the hyperglycemia in pregnancy, is rising. We Indians, by ethnicity, we are more prone to get diabetes. And with the aging woman coming to us as a pregnant woman, lots of PCOD girls, they becoming pregnant with the ART and the obesity is on the rise. So there's two things which I really don't want to stand between the academics by the stalwarts. and delegates. Another D. Just two tips I want to say to all of you who are listening today, that when you think of the diabetes in pregnancy or hyperglycemia in pregnancy, we are a little different from the our European counterpart. So don't think like them that we have only one 26-week glucose challenge test and our work is done. No, our work is not done. Initial booking, DIPSI test is must, which is recognized by the Government of India, that 50-gram glucose, 1 hour glucose challenge test is not the test to be done. It is a with full meal 2-hour glucose test with the 75-gram glucose is one shot test. And always give a nutritional counseling to your patient by yourself. Don't push to them directly to dietitian. And third thing which I want to tell you all, that if you manage this diabetes, you are really going to do a wonder till across the generation. So all the best, Komal, for your future endeavor. And no doubt, Niranjan is a very, very close friend. And I wish you all very best for your general, for your futures and the Foxy. Thank you so much.
Thank you so much, Ragini Madam, for being the guest of honor and giving your views and your address. And with that, we end the inaugural ceremony and we start the scientific session. And I hand over to Dr. Pousali and Dr. Munjal.
Thank you, Komal ma'am. So we have two lovely, wonderful talks which are very informative, followed by a panel discussion. So I would start with the session 1. Here we have a talk on screening and monitoring guidelines of diabetes mellitus in pregnancy. And the chairperson, I would be introducing the two chairpersons. Our first chairperson today is Dr. Kavita Singh Madam. She's the professor and HOD obstetrics and gynecology of NSCB Medical College, Jabalpur. Ma'am has been the WHO master trainer colposcopy and gynae oncosurgeon. She has been the organizing chairperson of AMPOGS in 2013, AOGIN 2013, Foxy Zonal Conference with UVA in 2022. Ma'am has been the past president of GOGS Rotary Club of Jabalpur and has been the state secretary of AMPOGS. She has more than 15 state and national awards, more than 45 indexed publications, textbook chapters, international scientific monograph colposcopy, and she has been the PhD guide in gynae oncology. Ma'am has been a passionate teacher for more than 23 years. We welcome you, ma'am, to this webinar. Our second chairperson today is Dr. Manoj Chellani, sir. Sir is the director of Ayush Hospital and Test Tube Baby Center in Raipur. He's the current chairperson of the Medical Disorders in Pregnancy Committee of Foxy. Sir has been the past president, Raipur OB-GYN Society, the organizing secretary, North Zone Yuva Foxy in 2011. He has been the chairperson-elect of CG ISAR from 2023 to 2025. Sir has many laurels to his credit, the founder chairperson, CG IAGE, vice president of CG of ISOPAP, and he has been awarded by the Chief Minister of Chhattisgarh. Welcome you, sir. And our speaker today is Dr. Komal Chavan, ma'am. It's an honor to introduce ma'am. Ma'am is the medical director of Chavan Maternity and Nursing Home. And thank you. I would hand over.
Yes.
So I'll hand over to the chairpersons.
So welcome chairpersons, Dr. Kavita Singh, Madam, and Dr. Manoj Chellani. And I'm going to start with my talk today. It is really great to talk something which is really close to our topic, and that is screening and monitoring in GDA. Just a minute. I'm trying to adjust. Not able to make it full screen. Wait just a minute. I stopped sharing it. Can you see my screen?
Yes, ma'am.
Yes.
But it is not in full screen, ma'am. We can
Yeah,
see the slide of your.
Yes, great. Yeah. It's just stopped. I don't know why. Sorry. I don't know why I'm not seeing the full screen option. Why my Zoom is not. I can move my slides, but I can't make it full screen somehow. Just a minute.
Ma'am, in below there is a play icon. I think so that was it.
Yeah. Okay, thank you. So I think that was a very good. So we start with screening and monitoring in diabetes in pregnancy and what actually obstetricians do. So when we talk about diabetes in pregnancy, we know it is the most commonest medical complication of pregnancy. And GDM is defined as a carbohydrate intolerance with recognition or onset during pregnancy and irrespective of the treatment with diet or insulin. And this is as per the DIPSI 2006. So here, when we talk about diabetes in pregnancy, we have two kinds of patients, which are known to have diabetes before pregnancy, that is pre-gestational or overt, or diagnosed during pregnancy, which is gestational. And in our country, the GDM prevalence is almost 16.55. And that is the reason universal screening in pregnancy has become so important. And that we will discuss. And why are we worried? Because we know that there is a disease and there is pregnancy. And when we talk about the effects of diabetes on pregnancy, we see a lot of miscarriages, preterm labor, congenital malformations, macrosomia, IUGR, IUFD, even preeclampsia, hydramnios, all these complications are with diabetic pregnancy. And pregnancy effect on diabetes, it will definitely exacerbate the diabetes which is existing. 10% will become overt diabetes later on. And also complications like nephropathy, neuropathy, coronary artery disease are very high in patients who have diabetes in longer run. So coming to know the main crux about screening and monitoring, we should know that the insulin requirement is really very important. The pathophysiology, that is the insulin requirement, usually increases till 9 weeks. Then there is a slight decrease by 16 weeks. And then it increases gradually till 36 weeks and drops gradually till term. And this is because of the effects during pregnancy, the transient decrease, which is there in early pregnancy, maybe because of the maternal insulin secretion, or the nausea which exists in the early pregnancy, or the fetus related. And the increase is because of the hormones in pregnancy, like the human placental lactogen, estrogen, progesterone, the cortisol, prolactin, insulinase of placenta, all the hormones which are there, they are going to definitely cause fluctuations of the insulin level. Maternal effects, we see a lot of polyhydramnios, preeclampsia, which we spoke, prolonged labor, obstructed labor, more chances of operative delivery. Even an atonicity is more because of the over-distended uterus or a postpartum hemorrhage, very, very common. And infections. Always diabetes and infections we need to worry about. Progression to retinopathy. And all these, when you have these end-stage complications, it rises to maternal morbidity and mortality. And the fetal effects, we just spoke about the fetal effects, but what is most important is the long-term effects are usually the GDM, which is passed on, and they contribute to the main non-communicable disease. So it will not be only the fetal effects, but there are also the long-term effects which we see in the neonatal period and in the adult life also. And neonatal period, we are just worried about all the factors that is apart from the respiratory distress syndrome, hypocalcemia, magnesemia, hyperbilirubinemia, and definitely the NICU needs to be really equipped. The centers needs to be really equipped to monitor the both mother and the babies. And this is what I was talking about, that the babies born will have the risk of all these, that is diabetes, cardiovascular disease, and impaired cognitive and motor function in the later life, and including obesity, which is the most biggest pandemic for the NCD, which is on the rise. So we really want to have this NCDs, to stop this NCDs from becoming a pandemic of NCD. And that is what the focus lies in screening and monitoring. So as per the WHO criteria, we know that hyperglycemia can be diabetes or a GDM. And what is diabetes in pregnancy? When we see the fasting, it is as per the WHO criteria, when the fasting plasma glucose level is more than or equal to 126 milligram per DL, the 2-hour plasma glucose is more than or equal to 200, following a 75 gram oral glucose load, and the random plasma glucose of more than or equal to 200 in presence of diabetic symptoms. And in gestational diabetes, again, the fasting, it should be diagnosed at in any time in pregnancy in one of the following criteria. So any of the following criteria means we know it's a GDM, and the fasting glucose is between 92 to 125. 1 hour plasma glucose is equal to or more than 180 milligram per DL, following 75 gram glucose, and 2-hour plasma glucose somewhere between 153 to 200. So that is how we diagnose GDM. So what are the high risk factors? We have maternal age. We definitely know the increase in the age, the increase is a risk. Increase in BMI increases a risk. Then ethnicity, it is Latin or Native American, Southeast Asian, family history of diabetes, PCOS, having a history of large baby or glycosuria adds to the risk. So low risk will be nothing under this. So less age, less BMI, no high risk factors, no family history is a low risk. So screening. Now, according to the American Diabetic Association, screening should be done for only high risk pregnancies. Dr. Ragini Madam actually pointed out very well that we really have to have our own criteria. But they have said that screening should be done to high-risk patients, that is, whose BMI is more, who has a macrosomic baby, or a previously diabetic, or a family history, or in an increased prevalence zone, or having PCOD, or insulin resistance. So screening can be done by any of the criteria, that is ADA, WHO, ACOG, DIPC, and IAD, PSG. So these are all the criteria. But what actually we follow, we are not going to discuss because the theory part of it, but the practical part of it. And what looks more practical is a WHO screening, that is the 75 grams 2-hour OGTT. That is 2 samples taken. That is the first sample in the first hour. That is 75 gram of glucose is given. That is a fasting sample. And then after 2 hours, you take a post-glucose sample and you monitor. So this is a very simple test. Patient comes, the fasting, you can give that glucose sample and the tests are done. And we discussed the cutoff levels earlier. But what is most recommended and what is more to be highlighted is the universal screening. And this is recommended by Foxy and PICO. And how to do it? That you screen every pregnant patient at the first visit using the DIC guidelines. And DIC is a single-step screening method and is highly recommended by both Foxy and PICO. And really, when we talk about our patients, the hour load what we have, we need to follow our own guideline, that is a DIPSI recommendation, which has come into existence in December 2004. And it is a diabetes in pregnancy study group. And we have Dr. Hema Divakar, who was so much active in DIPSI and for coming with our own guidelines. And we are very fortunate to have our people and know them closely. And what is this DIPSI guidelines? We give 75 gram of oral glucose food, irrespective whether the patient is in fasting or a non-fasting state. And then a blood sample is collected after 2 hours. And then when the values come more than 200 in both pregnancy and outside pregnancy, label as diabetes. If it is between 140 and 199, if it is in pregnancy, we label it as GDM. And between 120 to 140, it is gestational glucose intolerance. And if it is less than 120, it is normal. So we know that this is the cutoff which we follow. And when we do the targeted levels, and if you find it everything to be normal, it is not necessary that you need to just wait on and just sit in the pregnancy, but you can repeat the test at 24 to 28 weeks, and then it's required at 32 to 34 weeks. And always keep the targeted level, that is a fasting between 80 to 90 milligram per DL, and peak postprandial around 110 to 130. And even when we talk about our government, why OGTT is there? Because in the government sector, it becomes sometimes not possible to have the DIPSI testing, and the PMS guidelines also, the beneficiaries, irrespective of the high-risk status, should be offered OGTT. And if there is a OGTT positive, you need to have some red sticker on their paper so that these patients are actually monitored as a high-risk pregnancy and followed up later in the ANC period. So moving from screening to monitoring. So once a patient is screened, we talk about the Government of India guidelines. So once it is diagnosed, somebody as a GDM, what is advised is a medical nutritional therapy. We're not talking more about the therapy as Dr. Charmila is going to cover, but it consists of meal where carbohydrate intake is controlled and you give nutrients such that it is optimum nutrients given to both mother and the fetus. And then after doing this, when we need to do a blood glucose level 2 hour, that is a PPBS, and it's checked after 15 days. And after 15 days, if you find that it is controlled very much, you can just continue the MNT and exercise. But if it is not maintained and she is less than 20 weeks, then insulin therapy needs to be started. On insulin therapy, you need to keep the targeted levels between 95 to 120. But if they are not maintained and she is more than 20 weeks and her PPBS also is more than 120 milligram per year, then you can consider starting metformin, and the blood sugar levels are tested twice a week. With metformin can be started as 500 mg per daily, twice daily. You can increase till 2 grams per day. And here, the advantages is that it reduces the maternal weight gain. Also, the incidence of hypoglycemia, which we see in insulin, are really less. And the blood sugar level needs to be targeted and maintained. If not maintained, you can definitely switch over to insulin. And if the 2 hour PPBS is very high at initial diagnosis, you need not hesitate and start insulin. So this is how the Government of India guidelines. All the guidelines are more or less coming to the same perspective, but the NICE guidelines, which says that GDM is diagnosed, the patient is advised diet and exercise, reviewed after 1 to 2 weeks. If the target levels are not met, oral metformin insulin, and insulin is started at once if there is a contraindication, or if patient is not interested in starting metformin therapy, or the target levels of metformin are not achieved. Even alternately, glyburide is initiated if there is intolerance to metformin or patient refuses. And if the fasting glucose level is more than 7 millimoles at any time in diagnosis, or the fasting glucose is between 6 to 7, and if you feel that there is a high chances of having a hydramnios or a macrosomia, you need to start immediate insulin therapy. So that is the only indication for immediate insulin therapy as per the NICE guidelines. Then coming to the American College of Obstetrician and Gynecologists, they have said once GDM is diagnosed, start the nutrition therapy. If the targeted levels are not achieved, insulin therapy is given, and alternatively other medical oral drugs can be initiated. Even the American Diabetic Association said insulin is the first line of treatment, and metformin can be tried in GDM as has a higher risk of prematurity and unknown long-term effects on fetus are the concern. So they recommend insulin as a first line of therapy. Apart from the monitoring of the sugar level, we need to monitor the retinal assessment. Very, very important, because we really don't want patients to have any retinal problems. So a retinal examination once in pregnancy is required. And how do we keep the blood sugar values at range? So somewhere these are the normal values, what you see at this side of the chart. These are the normal glucose values. So when we talk about the self-monitoring, because patients are usually going to be shifted from the medical nutritional therapy to self-monitoring, and they need to keep their values. That is a fasting, which is really around 95, then pre-meal around 100, post-prandial around 140. So these values should be actually optimally maintained to get a good glycemic control. And during pregnancy, we really need to monitor the patient at every visit. So at 16 weeks is the optimum time to do the sugar assessment, the retinal assessment, and ultrasound at 20 weeks for structural anomalies, the heart anomalies. At 28 weeks, again, we need to do a growth scan with the amniotic fluid volume. At 32 weeks, you can repeat it at 32, 34 weeks. And at 36 weeks, the optimum time where we need to find out the changes in the blood sugar level, how the care of the baby, is your center equipped to manage the baby? Can we take the patient to the term? Everything can be discussed with the patient regarding the timing, mode, and management at birth. And likewise, if the patient is definitely under control and there is nothing, no fluctuation in the blood sugar levels and everything, you can safely wait till 39 weeks. But if there is any problem, or non-reassurance of the fetal parameters, or you feel that is an uncontrolled diabetes, you need to terminate it a little early, that is around 38 weeks. And fetal surveillance, as we do, is very important, but the tardive fetal kick count is something which is more practical, and every patient should be encouraged to do that. And when and how to deliver now. So there is an insufficient data to recommend against a cesarean delivery. If you have only a macrosomia, you can't just go for cesarean. But if you suspect a very high fetal weight, more than 4.5 kg, that is maybe the indication for cesarean delivery. Or women with gestational diabetes who have good glycemic control can actually be managed expectantly, and nothing to be done till 39 weeks. Now coming to the labor, how do you monitor in labor? Because this is a time where continuous monitoring is required. Patient may not be taking the regular medication or regular diet. So you feel that a patient who are on insulin or metformin, you can withheld on the day of induction. And women should be started on a 2-hour monitoring. And a glucometer can be kept handy. IV infusion with normal saline to be started regularly, and blood glucose level continuously monitored. And intrapartum monitoring is really, really important, so that we really know that if there is a need to start insulin. And if there is a need to start insulin, if the blood glucose level rises between 120 to 140, you start a 4 units in 100 ml per hour at 16 drops. And as the blood sugar level rises from till 180, you can increase the insulin from 6 to 8 units, and you can continue it and monitor the blood sugar level and maintain the levels. So after delivery, the postpartum period, it should not be neglected, and that is also the main important period. And screening should be done at 6 to 12 weeks postpartum for diabetes, impaired fasting glucose, or impaired glucose tolerance. And if you feel a positive, that there is a positive results, then patient needs to be referred, needs to be analyzed about the diet control. Repeated testing should be obtained. And also we can definitely keep this patient in the long-term follow-up. So follow-up is really important, that we need to test them every 1 to 3 years if the OGTT, everything looks normal. But if there is a family history or anything, then you might keep them on follow-up with doing an HbA1c test and OGTT, and also to counsel them regarding the future pregnancies. So this is in short, the flowchart of what we discussed about the monitoring and how we go about that. If there is a pregnant woman, you test in the first antenatal period. If it is positive, then you treat as per the GDM guidelines. But if it is negative, you again repeat, that is at 24 to 28 weeks. And then if anything is positive, you treat as per the guidelines. If negative, then you continue in normal pregnancy. Because you believe me, a patient you can detect a GTM at any stage of pregnancy. So you really need to be vigilant and keep monitoring. So I would end with a quote: motherhood is the greatest thing and the hardest thing. And at the end, just a sincere vote appeal, seeking your valuable blessings and support for the post of Vice President Foxy. I request you to please vote, support, and help me in my forthcoming election. Thank you so much.
Thank you, ma'am, for the wonderful insight. Dr. Pousali, ma'am, are you there?
Yes, I'm here. Yes, Dr.
Yes, ma'am. Yeah, over to you. Yeah.
So thank you, Komal, ma'am. That was a wonderful talk, and thank you to the chairpersons, Dr. Kavita Singh and Dr. Manoj Chellani, sir. And now I would like to move over to the next session. It's the second session with another wonderful talk. The topic is drug therapy and role of medical nutrition therapy. The speaker is Dr. Charmila Madam, and may I introduce our two chairpersons for this session. Our first chairperson today is Supriya Jaiswal Madam. Madam is the chairperson of Adolescent Health Committee, FOXY 2023 to 25. She's the present Vice President, Patna Obstetrics and Gynecological Society. She's the Chief Consultant at SM Hospital, Patna, and Executive Member of Central ISOPAP, Executive Member of ISAR Bihar Chapter, Executive Member of IAG Patna Chapter. She's trained in colposcopy at FOXY Certified Center. And ma'am has been the recipient of numerous awards and certificates and has held the posts of Joint Secretary, Clinical Secretary, Executive Committee Member, and Treasurer, as well as Secretary of the Patna Obs and Gynae Society. Ma'am has a special interest in high-risk pregnancy and preventive oncology. Welcome, madam. Our second chairperson is Dr. Jayshrijena Kapadia. Ma'am is a senior consultant obstetrician, gynecologist, and infertility specialist at Life Care Multi-Speciality Hospital and Shri Fertility Hospital and IVF Center at Daman since 2001. She has done her UG and PG studies from Government Medical College of Surat, South Gujarat University. She has training in basic and advanced ultrasonography, color Doppler, fetal echo course at Paras Advanced Center for Medicine. She has done an advanced ART course for clinicians at International Institute for Training and Research in Reproductive Health at Bangalore. She has done colposcopy training at Dr. Priya Ganesh Kumar Center at Thane. Ma'am has been past president of VAPI Obstetrics and Gynecological Society year 2016 to 2017 and has received the Shashakt Nari Shashakt Bharat Award on 8 March 2015 during International Women's Day. Ma'am has been the member of Foxy Adolescent Health Committee. She's a Dhira Master Trainer and has given many presentations at many state and national level conferences. Welcome, Madam. Now, I would like to hand over the session to the chairpersons. Before that, I would like to introduce our speaker today, Dr. Charmila Ayyavoo, Madam, who's the Vice President-elect of Foxy year 2024. She's the chairperson of Clinical Research Committee in Foxy since 2016 to 2018. She has been an ICOG Governing Council member from year 2021 to 23. She's the National Coordinator, UNICEF Foxy PCA, the National Coordinator, Medha Foxy PG Program, a National Coordinator at ISAR Gurukul 2022. She's the WHO CRO MDSR India member. She's been the past secretary of Trichy ONG Society, President Menstrual Hygiene Management Consortium 2018 to 20, and Joint Secretary Gestosis India Association. We welcome you, Madam, and I would like to hand over the session to the chairpersons.
Dr. Supriya, you can welcome Dr. Charmila.
Yeah, thank you and good evening, everyone. I would like to really thank Dr. Komal and Dr. Niranjan Chavan, sir, for making me a part of this very important session on diabetes. Actually, it was a series under the aegis of AGOG. And really, and thank Dr. Pousali for the wonderful introduction you gave. And thank you so much for making me a part. And I would really love to hear Dr. Charmila Ayyavoo. I would like to spell your name properly. And then she's going to talk on drug therapy and role of MNT. And before that, I'll also wish all the best to Dr. Komal for all your future endeavors.
Thank you so much. Thank you so much, Supriya, for that kind words which you said. And thank you to the coordinator, Dr. Pousali, for her introduction. We have to thank Dr. Komal for the opportunity. We have known each other for a long period of time. And I hope that she comes into the major work of Foxy in the future, and we wish her all the best. And we know that she'll do well. And I will just start my talk on MNT and drugs and GDM. Komal has done an extensive talk on almost all the aspects of diabetes and pregnancy and GDM. Mine is confined to MNT and drugs, which she has touched upon. I'll just summarize like what is needed for the management in our country. And when you want to classify hyperglycemia and pregnancy, it can be only two. It can be gestational diabetes mellitus, or it can be diabetes in pregnancy. Gestational diabetes mellitus, where it's just occurred or you're recognized during pregnancy. Before that, she was never a diabetic. In diabetes in pregnancy, it can be type 1 or type 2, and she was recognized earlier, and she's already been managed as a diabetic even before she became pregnant. I'll just confine myself to GDM today. It was defined as carbohydrate intolerance of variable severity with onset of first recognition during pregnancy, and that's according to the ACOG. Why do you need an optimum control of GDM? Because there are no symptoms in the patient, but we need to know that optimal control is needed to prevent a perinatal maternal infant complication. And you have to remember there's something called a concept of developmental origins of health and diseases, and the long-term effects on the baby after birth have been actively proposed in hyperglycemia and pregnancy. And when you have a glycemic control, it helps to maintain the health of mothers and infants in the short term, as well as in the long term, and also into the next generation. It's got such a long arm, and that's why you need to manage it perfectly during pregnancy. And according to the Government of India guidelines, any lady who tests positive for GDM for the first time during pregnancy should be first started on medical nutrition therapy and physical exercise for the first 2 weeks. And the non-pharmacological management is actually the most important part of management of GDM. It forms the cornerstone of the treatment. And when the patient exercises, It decreases her peripheral insulin resistance and is an appropriate adjunctive therapy to diet to the GDM patient. And that's why exercise with diet should be advocated to the patient. Every patient is encouraged to participate in exercise of at least 30 minutes several times weekly. Then even when you need to add a drug like metformin or insulin, you need to remember that there needs to be consistency of carbohydrate intake with meals and snacks. And that is a very important focus of any therapy for GDM. And how do you calculate the energy requirement for your patients when you're counseling them? It's actually the multiplication of the basal metabolic rate and the physical activity level of the patient. So for an adult lady who's around 18 to 30 years, you have to add the physical activity level of 14 into basal body weight for BMR, and then you add 471. And for a lady who's older, it will be 8.3 into body weight plus 788 for the BMR, and then you multiply with the physical activity level. The pre-pregnancy body weight should be always taken into consideration when you're calculating the requirement. And according to the ICMR, for an average weight gain of 10 to 12 kg during pregnancy, an addition of 350 kilocalories per day above the adult requirement is recommended, and that's during the second and third trimester. But this is a simpler way of calculation according to the Government of India. So suppose you think she's got a level of activity of sedentary work, her calorie requirement is 1,900 calories, and for pregnancy you add 350. So that makes it 2,250 calorie requirement per day. Suppose she works to a moderate level, then her calorie requirement is 2,230 plus 350 for the pregnancy. So it makes it 2,580. Heavy work, she can have 2,850 calories plus 350. So that's 3,200. Suppose she's an underweight patient, you reduce, actually add 500 calories. But if she's obese, you deduct 500 calories from the total requirement. This is quite an easy way of calculation rather than the other one of BMR with the physical activity level. And how do you ask the patient to count her calories? It needs to be that the carbohydrate has to be spread over 3 small meals and 2 to 3 snacks each day, rather than taking 3 large meals. And regarding the carbohydrates, which you need to advise is, she has to take more of whole grain cereals, whole pulses, vegetables, fruits with the skins. And that should be preferred over the simple carbohydrates like the regular food which she takes with lots of added sugar or honey. And any food that's made with refined white flour should be actually reduced, because those are all simple carbohydrates can get easily digested and increase the sugar levels. And the aim should be, she has to take 2 to 3 carbohydrate serves at each major meal and 1 to 2 carbohydrate serves at each snack. And saturated fat intake should be less than 10% of her total calories. When you add 3 servings of proteins, that actually will help to meet the increased demand of pregnancy. Instead of adding the carbohydrates, you can add proteins. There's another simpler way according to the DIC guidelines of 2021, where for the carbohydrate, they say every part of the food, like day-to-day food intake should be breakfast, lunch, and dinner. 3 servings if she's taking. Each serving should have a carbohydrate intake of only 45 grams, and the snack should contain 30 grams of carbohydrates. Proteins, for a vegetarian, the choice is thick dal or whole pulses, and that's 2 to 3 cups a day. But if she's a non-vegetarian, she's got a choice of eggs, chicken, or fish, and that can be 2 eggs per day, or cooked chicken or fish in a cup, and that's served with 1 cup of dal. For fat, she can use 20 ml per day of cooking oil, which is actually 4 teaspoons. And she can take toned milk, which can be in the form of milk or curd. And after second trimester, the milk intake, which was 500 ml in the first trimester, can be increased to 750 ml per day, which can be milk or curd. So there's another simpler way of calculation. She can take a 10-inch radius plate, half of the plate for each meal. It should contain cereals, whole grains, or millets. Quarter should contain the proteins, which can be in the form of dal and whole pulses for vegetarians. For a non-vegetarian, it will be egg, fish, chicken, or mutton, and actually dal also. But that's for the quarter of the plate. And for the rest, the other quarter of the plate, it should be filled up with green leafy vegetables, watery vegetables, the traditional vegetables which are available in her place, and the beans. That should fill up quarter of the plate. So this is the way she eats, and she has to get up and go off. She's not supposed to eat more than that. If she gets hungry in between her meals, then she can have a snack, which should be preferably roasted or boiled Bengal gram and sprouts or salads. And she can add curd 200 ml for breakfast, lunch, and dinner. This is a very simple way of calculating for a person who's been diagnosed with GDM, which is a little easier to follow than telling her take 2 serves and 3 serves, which most of the women do not follow. And when you're putting a patient on medical nutrition therapy, is blood glucose monitoring essential? Because most of us think that it's not needed, but definitely blood glucose monitoring should be done even if she's only on diet plan. And according to the American College, they do a daily monitoring with fasting and 3 postprandial levels. And self-monitoring is much better instead of her going and sitting in labs throughout the week. And once her target levels are met, the frequency of testing can be reduced. And if the target levels are not met, then she will be then drugs need to be added in the form of any form of pharmacological therapy. According to the Government of India guidelines, the monitoring in a person who's maintained on medical nutrition therapy is not so stringent. You can actually do after 15 days after you started on MNT, and you can check only her 2-hour post-meal. You don't need to do her fasting. And suppose she's maintaining a postprandial blood sugar at less than 120, that means her MNT and exercise is working for her. So the testing can be then reduced. They say you can do 1 test per month till she completes her pregnancy. But if you feel that she's not controlling herself, you can actually add on the number of tests which is done, and that's done as your discretion. But remember, even in a person who's on diet alone and exercise, you need to monitor her sugars. Yeah, it may be a medical legal problem if you're not monitoring her and she lands up with a complication during pregnancy. And according to the other guidelines, as I said, the American Diabetic Association needs her to test every day, and they set up a target of fasting level of 95 and a postprandial of 140 for the first hour and 120 for the second hour. Preprandial levels are not needed for managing GDM patients, according to the American Diabetic Association. It's needed only for persons who are diabetic and who are already diabetic and they are now pregnant, for pre-existing diabetic patients. And remember that HbA1c is not useful in monitoring a patient who's a GDM patient. So what is a pharmacological therapy? You will start when she's not controlling herself with medical nutrition therapy and exercise. Then you need to add either insulin or the oral hypoglycemic agents. And we have to remember that almost 25 to 50% of our women with GDM will require insulin or oral agents as the pregnancy progresses. And the agents which are advocated are metformin, glyburide, and acarbose. Metformin is the main drug which has been successfully used for almost 40 years to treat diabetes outside of pregnancy. So we know the safety profile of the drug, and it's used during pregnancy as an alternative to or an addition to insulin. And it works very well because it improves the insulin sensitivity. And we know that GDM is basically because of the resistance at the placenta level to insulin. And that's why the patient becomes diabetogenic as she progresses. So this drug has got a physiological action of improving the insulin sensitivity, and probably that will cause a fall in the insulin resistance. And this drug has been already studied in the first 12 weeks of pregnancy in patients who are conceived with a polycystic ovarian syndrome. It's a biguanide agent, and it can be, the main indication it's used after 20 weeks of pregnancy for medical management of GDM. And when a person is diagnosed with GDM before 20 weeks, the choice is much different. And when you start at a dose of 500 milligram twice daily, and you can increase up to 2 grams according to the Government of India. And you have to remember that hypoglycemia and weight gain with metformin are definitely lesser in comparison to insulin. And when you need to add insulin because she needs better control because she's not getting control with metformin, you can actually continue metformin when you're giving her insulin also. And the common side effect that happens with metformin is diarrhea, nausea, stomach ache, heartburn, gas, and the serious side effects are lactic acidosis and hypoglycemia. So that we have to remember and talk to our patients when you're prescribing metformin. And when you're putting the patient on metformin, do not think that monitoring once in a month is enough. It's not enough. You have to do it once in 3 days. A bi-weekly testing of both the fasting and the 2-hour postprandial needs to be done when the patient has been shifted to metformin from medical nutrition therapy, and the adjustments of the dose will need to be done to maintain normal blood sugar levels. And once she is controlled, then probably you can shift her to a once monthly testing, but that should be at the discretion of the physician. The next drug which has been tried is glyburide. It's a sulfonylurea, and its primary action is to actually enhance insulin secretion. The starting dose is 2 milligram to 2.5 milligram in divided doses. You can go up to even 30 milligrams when necessary. But remember that hypoglycemia is very common with sulfonylureas, and glyburide is no exception. And the same side effects like metformin can happen in the form of gastrointestinal side effects, but addition of dermatological side effects can happen with glyburide usage in the form of pruritus, urticaria, erythema, and maculopapular eruptions. The third drug which has been tried is glucosidase inhibitor, acarbose. It will reduce the intestinal absorption of starch, and that will reduce the rate of complex carbohydrate digestion. And this will help to lower the postprandial glucose levels after a meal. And it has been used in type 2 diabetes for a long term. But it actually works because it only 2% absorption will happen in the maternal circulation of carbohydrates when this drug is used. It's got potential benefits. But remember that when the bacterial breakdown of starch happens, it can lead to an accumulation of butyrate, which could increase the prostaglandin E secretion, which can have negative consequences on pregnancy. And this is one side effect of acarbose. So at present, these drugs are not recommended because of the lack of human pregnancy safety data. So what about insulin? If unable to achieve a glycemic control with diet and exercise, actually insulin is the first drug to be recommended. It's very safe and effective, and it's a gold standard against which other therapies are compared. And the insulins which has been used are the regular insulin and NPH, and the short-acting insulin analogs are actually now preferred, the Lispro and Aspart, which are considered safe for use. Indications for insulin, you can start at any time during pregnancy for GDM management, and particularly if you've diagnosed GDM before 20 weeks and her MNT therapy has failed, actually it's better if you go for insulin instead of giving metformin. And at the initial time when you've diagnosed GDM and your 2-hour postprandial is more than 200, it's better that you go for insulin rather than giving metformin, which may not help such a patient who's got high sugars at an earlier part of pregnancy. But the disadvantages of insulin therapy in GDM is there because it's quite imperfect for these reasons. You need lots of education to a patient who does not even understand that she has got a disease, and it needs subcutaneous administration. You need to titrate the dose. Hypoglycemia and weight gain are real complications of insulin therapy. There's a limited acceptance, and there's definitely a high cost. They say there's a psychosocial deprivation which a patient feels when you give insulin to a patient with GDM. And we have to remember that health accessibility to this drug is quite unequal in our country. And that's why the trial for oral hypoglycemic agents are like glyburide and metformin has been tried even before insulin can be given to a patient. According to the American College, when you start a patient on insulin for GDM, the dosage has to be weight-based, and it's 0.7 units per kilogram body weight as a starting dose. And once you're calculated based on a body weight, you divide it into 2/3 for the morning and 1/3 for the night. And when you give the morning dose, it should be 2/3 NPH and 1/3 the regular insulin. And when you give it at bedtime, it's better if you give 1/2 a regular insulin before dinner and 1/2 of NPH insulin at bedtime, so that it takes care of the fasting high sugars. But there's an alternative regimes because it's 0.7 milligram per kilogram body weight is quite a high dose for many of GDM patients, and they tend to go for hypoglycemia. So there's an alternative regime by Dr. Stephen Gabay, who said you give NPH 15 to 20 units in the morning and monitor her sugars. And if it's controlled, it's quite good. But if she's got a fasting glucose which is high, you may need to add a bedtime dose of NPH. And suppose her in between meals, there's a elevation, then you have to add rapid acting insulin 5 to 10 units between the morning and night dose. Dr. Muralidhar Pai of Manipal Hospital actually came out with an easier method of giving insulin for GDM patients. And he says for initial control, you give 4 of your short acting insulin actrapid. And once the target levels are obtained, you change the dosage which you've given to the patient to NPH of 2 doses. And if there's fasting hypoglycemia, increase the NPH level at bedtime. That's a simpler regime by Dr. Muralidhar Pai. But the Government of India guidelines is also equally simple for GDM. So you give a NPH insulin for any patient with GDM. And suppose her blood sugar is between 120 to 160 postprandial, you give 4 units. It's 160 to 200, you will give her 6 units. And if it's more than 200, start at 8 units of premixed insulin 30/70. And you check her blood sugars, fasting and 2 hours postprandial every 3rd day. The target should be fasting of less than 95 and a 2-hour postprandial of less than 120. And suppose her fasting sugars are normal with the dose you've given, but her 2-hour postprandial is high, you will increase a morning dose of insulin by 2 units, that is NPH. And you will add MNT and physical exercise even if she's on insulin therapy. But after you started the dose and still both levels are high, you will increase the morning dose by 2 units and the night dose by again 2 units. So this is very simple. Postprandial sugars is elevated after the initial dose. You add 2 units pre-breakfast. The fasting is elevated. You increase pre-dinner the 2 units of NPH. So what is the difference between metformin and insulin for GDM therapy? There was a big trial in 2008 called as the metformin and GDM trial. And metformin was compared to insulin in the treatment of GDM. They found out there's no great difference between these therapies with respect to the neonate. But there was a higher risk of preterm deliveries and a higher risk of neonatal hypoglycemia, which was quite severe in the metformin group compared to insulin. And 45% of women in the metformin group needed additional insulin therapy for glycemic control. So I would like to say that the Government of India guidance is very simple for GDM. Once GDM is diagnosed, mother is put on MNT and exercise. And when on MNT, if a blood sugar, after 15 days when you're checking 2 hours after a meal, if it's less than 120, she continues on medical nutrition therapy and exercise. But if she's not maintained at 120 and she's still less than 20 weeks of pregnancy, insulin will be the first choice. And when on insulin therapy, check her blood sugars fasting and 2 hour postprandial every third day or sometimes even more frequently. But if she's more than 20 weeks and her postprandial sugars are not controlled and she's more than 120, you can consider starting metformin. Even when on metformin, the blood sugars are tested twice in a week. And if the target levels are not maintained with metformin, you have to start insulin. American College, the target levels, they have fasting 1 hour and 2 hours. And if there's no control of MNT, for them, the first choice is always insulin. Daily monitoring is essential according to American College. Metformin only if she declines insulin. And when you're starting metformin, you have to check the baseline creatinine according to the American College. The NICE guidelines, the target levels are little, there's not much of difference, just 1 or 2 levels. But if there's no control with medical nutrition therapy, the first choice according to the NICE guidelines is metformin. And you've given metformin for 1 to 2 weeks and there's no control, you will put her on insulin. But if the fasting levels are very high when you're starting therapy with medical nutrition or with metformin and it's more than 126, insulin will be the first choice. Glibenclamide can be given if she refuses or she's not controlled with metformin according to the NICE guidelines. So this will be a summary of all the guidelines. All guidelines say first line therapy is medical nutrition therapy. Second line, according to the Indian guidelines and the UK guidelines, is metformin. American College and the American Diabetic Association, the first choice is always insulin. And you give glyburide metformin if she does not want insulin or the compliance is very poor. And third line therapy in all the guidelines is definitely insulin. So to conclude, medical nutrition therapy is a cornerstone in the management of GDM. Insulin is considered the best therapy for a good glycemic control in patients with GDM, but it's expensive and needs lots of motivation for the patient. And that's why oral drugs like glyburide and metformin are tried. But when both the oral drugs are being tried and there's no optimum control, you will need to add insulin. And remember that metformin needs to be used with caution as it crosses the placenta, and we do not know the long-term effects of this drug on the fetus. And remember that glyburide is associated with a higher incidence of neonatal hypoglycemia. Both the oral drugs are less effective when the fasting sugars are very high or GDM has been diagnosed at the earlier part of pregnancy. Then the above factors should be considered before the initiation of therapy in patients with GDM. Thank you so much for the opportunity. I would like to wish Dr. Komal Chavan all the best. Thank you so much.
Thank you so much, ma'am. May I request the chairpersons to have the concluding remarks of the session, ma'am?
Dr. Jayshri, I think you have to unmute.
Yeah.
Thank you so much, Charmila ma'am. It was a very informative, very detailed talk on diabetes mellitus in pregnancy, including the medical nutritional therapy, all the drug therapies we should use, the metformin, followed by all the other drugs which we use, and followed by the insulin, which is the gold standard for diabetes and mellitus in pregnancy. Thank you so much, Charmila ma'am. It was a really pleasure. Dr. Komal, thank you for having me here in this wonderful webinar.
Can I ask one question to Dr. Charmila?
Yes.
I just want to ask if I am, suppose a gynecologist is competent enough to deal with insulins and deal with the patient. So is it necessary or medical legal point of view to show the patient to physician or a diabetologist?
No. No, if when you show to a physician, they'll totally confuse you and the management goes haywire.
That happens usually. That is why I was asking.
We should manage.
Medical legally, it's not.
No. When she becomes diabetic during pregnancy, she's an obstetrician's treasure. She's not supposed to be given to a physician.
Yes. As usual, your talk was wonderful.
Thank you, Supriya. Thank you so much.
Thank you.
Thank you, Dr. Charmila. I think it was a lovely talk, and I knew you were the best person to talk on the medical nutrition therapy. You have also contributed to the newsletter, which I think Munjal has only edited.
Yes.
We really, because it was really the clarity in which you can actually pass on the information that is most important, because sometimes we get so much confused when we read so many guidelines and we are really confused what actually we should follow. And that clarity was there in your talk. Thank you so much.
Thank you, Komal. Thank you so much.
One thing I just want to ask you, as well as I would like to point that the importance of weight loss in diabetes patients in pregnancy. We have to be very careful regarding the weight gain the patient has during pregnancy. We have to check it during the whole tenure of 9 months to get a good glycemic control. Don't you agree, ma'am?
Yeah, you should. See, weight gain, even if she's not a diabetic, is going to cause problems for the pregnant patient. So weight management is extremely important for most of our patients now. And always look at the patient's card when you're talking to the patient, because many times we see they have that function in Tamil Nadu and all when she becomes pregnant and they keep on feeding her. And within a month, she'll put it 4 kgs and come. And sometimes it may be otherwise also. It can be because of a preeclampsia which is starting and we will not even know. But with a weight gain, we'll know that she's going to go for a preeclampsia also. So weight is extremely important for every pregnant patient. And that too, when there's an NCD happening, I think it should be always taken into consideration. Look at it always. But even if you counsel her, she's not going to listen, but at least put it in her mind that she can't put on more than a particular limit. Manju Puri madam is there. Good evening, madam.
Good evening. Good evening. Very nice talk.
Thank you, ma'am. Thank you.
But I think, can I just add a point?
Yes, ma'am.
Yes, ma'am.
So basically, you must remember that the patient should not lose weight when she is pregnant. Some amount of weight gain has to be there. And because sometimes when you decide to put them on insulin, they stop eating. And then they can end up with FGR. So I think we have to be cautious about that also. So it should be a limited weight gain in those who are overweight. Yeah.
But that's minuscule, madam. Many actually put on weight after our counseling.
Absolutely.
Thank you so much, ma'am.
Thank you.
Yes, ma'am. Can we proceed to the next session? That is panel discussion on the DIC in pregnancy. Can we have the CV slide of Dr. Pushpa madam, the moderator? Yes, Dr. Pushpa madam, MD, FIMCH, professor. She is a professor and HOD at PD MMC Amravati, member of UG and PG Board of Studies of Surgery and Allied Subjects at MUHS. First visiting professor sent by Foxy to Cuttack Medical College, Odisha. She is PhD guide. Faculty in many national, state and zonal conferences, CMEs and workshop. UG and PG examiner at various universities in India. Past president, Amravati OBGYN Society, organizing secretary of State Conference of AMOGS in 2005, organizing chairperson for AMOGS 2020 at Amravati, peer reviewer of the Journal of Jogi, that is Foxy journal, instrumental in establishing the first human milk bank in central India at PD MMC Amravati. She has many awards and accolades and many publications in national as well as international journals. We welcome you, ma'am, Dr. Pushpa madam, as moderator of panel discussion. Can we have CVs, yes? Dr. Manju Puri madam, as an expert of this DIC in pregnancy panel discussion. She is director professor and former HOD of Department of OB and GY at New Delhi. She is chairperson of Safe Motherhood Committee of Association of Obstetrics and Gynecology of Delhi. National Coordinator of Practical Obstetric Committee of FOXI, President National Association of Reproductive and Child Health of India, Delhi. She is member of many technical expert groups formulated by GOI, expert quality assessor of public health facilities. She has edited books naming anemia in pregnancy, management of high-risk pregnancy, a practical approach, clinical methods in OB/GYN, and she is having field of interest in form of high-risk obstetrics, quality improvement, and reproductive endocrinology. Dr. Pushpa, madam, the stage is yours. And yeah, thank you. Thank you, ma'am. Would you be comfortable for introduction of panelists, or should I introduce ma'am?
Please go ahead. Then I'll take over.
So yeah, sure. Thank you. So the panelists are Dr. Shakuntala Kumar, ma'am. She is a senior consultant, Fortis Hospital at Shalimar Bagh and New Life Hospital, GTB Nagar, vice chairman of the PDG, CMLS, DGF, scientific advisor, DGF North, life member of various associations, past secretary and vice president of DGF North, past chairperson, Adolescent Committee, AOGD, 2017-19, executive member of Adolescent Committee, AOGD, ex-joint editor, Delhi ISAR, ex-treasurer, ISPAT, Delhi chapter, recipient of President Abdul Kalam Award, and around 15 publications to her credit. Can we have the next slide, please? Dr. Poonam Goyal, ma'am, she is HOD, IVF Max Hospital, Delhi, director and HOD of OB/GYN, Delhi. There is Panchshil Hospital, author and editor of 6 books related to OB/GYN, past president, IMA, EDB, past member of PCP&DT Advisory Board, Delhi State, past North Zone Coordinator, Breast Committee, FOXI, past member, Infertility Committee, FOXI, and various awards to her name. Next, please. Our next panelist is Dr. G. Soumini. She is Professor OB/GYN, AMC Visakhapatnam, Andhra Medical College, and Chairperson of Scientific Research Committee Resource Faculty, RCMET, AMC, membership of various associations, OGSV, Executive member, Public Awareness Committee, Organizing Committee, Yuva FOXI, awarded with FOXI Dr. Jagdeshwari Mishra Prize, Andhra Medical College, Rangaraya, MC. There is appreciation for services, Best Medical Officer, PPTCT, Guntur Medical College. She has various awards as well. She has been trained in Harvard and T2T ATCOM modules of medical colleges. Can we have next slide, please? Our next panelist is Dr. Sanjib Dutta, consultant obstetrician and gynecologist, associate professor at College of Medicine and Segor Dutta Hospital at Kolkata, managing committee member of DOGS 22-23, PPH workshop convener of AICOG Kolkata 2023, organizing committee member of AICOG, secretary Adolescent Health Subcommittee, BOGS 21-22, member of FOXI, ISOPAB and various associations. He is associate member of RCOG UK, presented various papers and have various publications. Can we have the next panelist, please? Dr. Indranil Dutta, again, a young expert in form of Professor, Medical College, IQ, that is City and NH, Durgapur, West Bengal, immediate past president, KOGS, executive member of YTP Committee, FOXI, past East Zone Coordinator under FOXI President, IMA Standing Committee member for antimicrobial resistance for the year 2018 to 22, published many articles in various index journals, articles for reputed journals included in PubMed as well. Contributed chapters in various books, around 20 books, FOXI books, editor of 2 books, including FOXI Focus on Drugs Update, organized the South FOXI conference in, 5 FOXI conferences in Calcutta and 10 other CME and local body conferences, member of various associations and many accolades to his name. Can we have the next panelist, please? Dr. D Geetha, ma'am. She is head of Department of OB/GYN at Dindigul Medical College and Hospital, Dindigul, MBBS and DGO from Madurai Medical College, Madurai, MD from Stanley Medical College, Chennai, presented many papers in national conferences, recipient of AI Modalier Fellowship Award, past honorary secretary of OGSSI, member of various associations. Can we have next panelist, please? Okay, sure. Thank you. We welcome all the moderator, expert, and the panelists for further discussion on DIC and pregnancy. Thank you.
Thank you, Dr. Munjal, for the kind introduction. Welcome you all. Dr. Manju Puri as an expert and all the learned panelists. I think I'll share the screen. Hello.
Ma'am, your screen is not seen, ma'am.
Okay, is it visible now?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Full screen nahi.
Can you, yes, ma'am. Can you make it in full screen mode, ma'am?
So all our panelists are being introduced?
Yes.
Ma'am, can you please make it in full screen mode, ma'am?
Yes.
Down there is a play button, yes.
Thank you.
So disseminated intravascular coagulation is one of the worst nightmare we encounter in our obstetric practice. DIC is thrombohemorrhagic disorder occurring as a consequence of aberrant activation of coagulation cascade seen in association with some well-defined clinical situation. We'll see them in our case discussion. Dr. Poonam, what are the changes in coagulation in pregnancy? How different it is from a non-pregnant person?
Pregnancy is actually a hypercoagulable state as compared to a normal individual. Due to various adapted changes which happen in pregnancy and various hormones are there is hypercoagulability. There is increase in the levels of clotting factors like factor 8. It increases almost by 100%. And there is other procoagulants, they also increase like factor 7, factor 9, factor 10, fibrinogen, and then thrombin. And on the other hand, the anticoagulants, they decrease, like the protein S, there is deficiency or there is low levels of protein S, and protein C and antithrombin 3, almost they are in the similar level, but sometimes they are also less in pregnancy. So as a result, what happens, the procoagulants are more in number, and the anticoagulants, they have decreased. So there is hypercoagulability in the pregnancy state.
Right, madam. Dr. Sanjib, what goes wrong when there is DIC in pregnancy?
Thank you, ma'am, for keeping me included here in this panel. Actually, in normal pregnancy, what happens, there is a complex interplay between three systems, like coagulation system, like coagulation inhibitory system, and fibrinolytic system. So what happens, normally the blood doesn't get coagulated because of the natural and anticoagulant that is there in the blood in the form of antithrombin 3, protein C, protein S, just like Dr. Poonam ma'am has already mentioned about it. And obviously for these reasons, and there is no coagulable state in these circumstances. But what happens in DIC, this pathologic balance between the coagulation system and anticoagulation system gets lost, and simultaneously, because of some reason, because of the reasons that causes DIC, there is a liberation of many factors like phospholipids, thromboplastin, and because of endothelial damages, there are these are all these inciting factors. So these ultimately leads to DIC, and ultimately the balance is lost. There is microcoagulopathy that happens everywhere, that damages all the end organs, and that leads to again dilutional coagulopathy, and again the fibrinolytic system starts getting activated, and that leads to further hemorrhage, and that leads to massive hemorrhage at the end. So that's what happens in DIC.
Basically, it is characterized by intravascular microcoagulation leading to formation of microemboli, and then they are going to lodge in different vital organs, and that is going to cause damage to majority of organs, especially like kidneys and lungs. Then there is fibrinolysis, consumption of coagulation factors and inhibitors of coagulation, and this may result in severe uncontrolled hemorrhage. That is finally when the patient is going to deliver from the placental side, and from other sides also she is going to bleed heavily. And of course, because of formation of microemboli, there is end organ damage. Dr. Shakuntala, what are all situations in obstetrics which can give rise to DIC?
So thank you, madam, and thank you, Dr. Komal, for giving me this opportunity. Well, DIC itself is not a specific illness. It is basically a complication or an effect of the progression of the other illnesses that are going on, you know. So whenever there is severe sepsis or infection, or whenever there is trauma, malignancy, conditions like this, DIC may happen. In obstetrics specifically, if we ask, then things like amniotic fluid embolism, pulmonary embolism, whenever there are elevated liver enzymes, low platelets, that is the HELP syndrome, eclampsia, preeclampsia, whenever there is any organ damage, end organ damage like severe pancreatitis. So these are the conditions where you can have a DIC. Conditions like molar pregnancy, when some things, cellular division is unabated, these are the conditions where DIC may happen.
Right. In practice, most of the times we come across DIC in patients of severe eclampsia, preeclampsia, and in abruptio placenta. The other things, they are rare, but we do come across patients coming with intrauterine fetal death, and they are staying at home, not coming in time. And they are also patients whom we might have to deal with complication of DIC. Now, keeping this in mind that there are so many problems which can lead to DIC, we'll see these cases. Nancy, 32 years, gravidad 2, para 1, living 1 with previous cesarean section, was admitted at 34 weeks with blood pressure of 160/110. She was not having any complaints except swelling over her legs and feet. On examination, her GC was fair. She was well oriented. She was afebrile. Pulse was 88, regular. Blood pressure was 160/110. Reflexes were normal. There was bilateral pedal edema. Cystic examination did not reveal anything abnormal. Uterus was 34 weeks. It was relaxed. Cephalic presentation. Vertex was floating. There was no scar tenderness. She was a patient of previous cesarean section. Fetal heart rate was 140 per minute regular. Her PIH profile, main investigations, hemoglobin was 10.4 grams per dl. Platelets were 140,000. KFT and LFT, they were within normal limits. Serum uric acid was 4.8 milligram per dl. Urine albumin was ++. And fundoscopy revealed grade 1 retinopathy. Her further investigations like obstetric USG revealed a single live fetus in cephalic presentation. Placenta was fundo-anterior in upper segment, grade 2 maturity. Fetal weight was 2 kg, estimated fetal weight. AFI was 8 centimeters and color Doppler was within normal limits. When this patient, she was admitted, she was already on 100 milligrams labetalol, which was already prescribed outside. When she came during that admission, she was given intravenous labetalol, 20 milligrams stat on admission. Labetalol was increased to 200 milligrams BD, and in the evening of her admission, Nicardia was also added. Nicardia retard 10 milligrams added twice a day. Her BP fluctuated from 150/106 to 140/100 for the next 48 hours. On third day, she complained of sudden pain in abdomen, which was all over abdomen, and she also started having backache. She also complained of bleeding per vagina. On examination, her pulse was 110 per minute. BP had shot up to 180/110, and she appeared paler as compared to when she was admitted. On examination, her uterus was 36 weeks, tense and tender all over, and was not relaxing. It was becoming more hard with contractions. The fetal presentation was not clearly made out. We initially had examined and found out it was vertex presentation. FHS were irregular, varying from 110 to 160 per minute. And on pervaginal examination, we did her pervaginal examination because placenta previa was already ruled out. Cervix was soft but undilated and uneffaced. Dark colored bleeding was there, which soiled her clothes. Dr. Soumini. So what is the diagnosis in this patient?
Good evening, Dr. Pushpa, and good evening, Dr. Manju Puri. I thank our Dr. Komal for making me a part of this. And because with her for the past year, we worked in the various medical disorders programs, including anemia and hypertensive disorders. Thank you, ma'am. And coming to the question, and this is a case when we are discussing with the case of disseminated intravascular coagulation. This case is a particularly at-risk case of DIC because the risk factors here are, one is preeclampsia which the patient has, and the other thing we should suspect abruptia placenta when the patient has complained of pain abdomen along with the bleeding PV. So here placenta previa was ruled out, and it is a case of preterm pregnancy associated with fetal distress. A case of gravida 2, para 1, live 1 with a preterm pregnancy of 34 weeks gestation with fetal distress and set in abruptia placenta, definitely a risk case of DIC. Now she could be in a phase of non-overt disseminated intravascular coagulation. The only thing is, one is because DIC is always secondary to the underlying cause, and out of which abruptia placenta is the main cause which we see in our clinical practice. So termination of the pregnancy, one part is to save the fetus, the other is for the betterment of the mother. But definitely DIC is at risk when you don't bother about the safety of the patient. But still, you have to take all the precautions, including the risk scoring of the DIC non-overt type here. It could progress to the overt DIC also. To keep on hand all the resuscitative methods, including hydration, blood and blood products on reserve, and all the investigations to detect DIC if the patient is going to have. And then there's no other go but do an MS because the patient is in early labor only, and also a case of post-cesarean pregnancy with fetal distress and preterm labor. I would prefer to get a repeat emergency cesarean section with due precautions, including the expertise help and also keeping in back about all the blood components if anything bad is going to happen, including and sending the investigations and keeping in reserve the blood components, we can advise, because abruptia placenta is one where the injury disease itself incites the coagulation system again.
So in this patient, abruptia placenta was the clinical diagnosis.
Yes.
And so we were worried about all the complications of abruptia placenta, including DIC, renal failure, and of course hemorrhagic shock. So this patients were, she was resuscitated or she was put on IV intracath.
Always resuscitate, and they keep in reserve about the blood products and all proceed to the surgery.
Yes. So the following investigations, they revealed hemoglobin had fallen to 7.2 from 10.6. Platelet also fell to 80,000. Urine albumin was also increased. Bedside clotting time was 10 minutes. And PT was 20 against control of 14. So INR was 1.4. APTT was 40 seconds. And D dimer was 5526 nanograms per ml. So everything
The other complication, madam, the other complication which we should keep in mind with the case of a preeclampsia is HELP syndrome as a complication, which is also a forerunner for DIC. All the investigations to rule out the HELP also have to be conducted.
Yes, but finally, the management has to be keeping in mind that she is also in disseminated intravascular coagulation, plus she needs emergency cesarean section.
Yes.
So this is important. That is, whenever we want the pregnancy to be terminated for maternal as well as fetal sake, but the patient is also in DIC. In fact, DIC is a contraindication for carrying out operative delivery or cesarean section. In fact, that is the only contraindication for cesarean section. But in this patient, it was necessary to save the baby because it was in distress and almost full term. So there are very good chances
also
that
the patient did not manifest she was a non-overt DIC when you started the procedure.
Yes. So basically, when such patient comes with severe preeclampsia, we should be prepared to handle all the complications which might appear anytime, not out of blue, but they are expected. So we should be prepared to handle such complications.
Yes.
So any patient of severe preeclampsia can land up with abruptia and subsequently in DIC, or even with HELP syndrome, she is going to have this complications. So we should keep all these things ready because they might be required anytime in emergency. Like for component therapy is the mainstay of treatment. And for that, we have to keep Paxil, FFP, and platelet also ready if platelet starts falling down rapidly and they are below 50,000.
Depending upon the
Dr.
investigative
Indranil
Yes,
and
yes.
Dr. Geetha,
Good
any
evening,
inputs
ma'am.
from you?
Yeah,
in the given
ma'am.
case?
As you rightly say, we have to deliver as early as possible this patient. This is a definite, definitely she needs emergency cesarean section because she's a case of previous cesarean, all the more going for DIC, and her platelet was at present more than 50,000, so no need of worrying taking under spinal anesthesia. Rightly, emergency cesarean should have been done with the backup of component therapy. Hemodynamic stabilization is of utmost importance now, and the aim should be hematocrit at 25 to 30% or higher, and output, urine output should be at least 30 ml per hour. We have to replace the losses with blood and plasma expanders.
So, Madam, can I join the discussion?
Yes, sir. Yes, sir. Please, yeah. Dr. Indranil.
So, very nicely told by all the esteemed panelists. What I would like to add, because I am working in a tertiary care medical college hospital, we keep getting a lot of patients like this with hypertension, particularly the type of patient who we are suspecting maybe uncontrolled hypertension, preeclampsia, particularly the type of abruptio placenta, that is a concealed type, is the most dangerous type because first of all, it is concealed. Secondly, it is very difficult to analyze unless clinical estimation of the blood loss or clinical estimation of the patient. Basically, it is a clinical diagnosis. We have to rule out the concealed type of abruptio because if the patient keeps on bleeding and she already goes or sets into the DIC, then no matter how much we try, we will all land into a deep sort of trouble. But as said, fast action and preparing a team, keeping the team ready. The advantage with the medical colleges are that we always have the team ready from junior to senior level. Call for help as we do in postpartum hemorrhage cases, and obviously analyze the hemodynamic status of the patient as soon as the patient lands into the ER. Now, any sort of, we know the basic factor that shock should be treated by replacement of the blood and blood products. Blood products, particularly now when we go from the medical college setup, we go out towards the rural nursing homes and the hospitals where we work in the peripheries. We know how difficult it is to get the blood products. So proper initial assessment, and if the management is not available in the distant tertiary center, proper transportation, all these comes under the aegis of proper management of the patient. So not only how to treat the patient, but how to diagnose the patient clinically by the resident doctors, particularly the young generation doctors, and to treat is very important. Now coming to the use of the component, it is itself a huge chapter and a huge topic as to which component should be used. So the use of PRBCs and FFPs, the role of them are very important in particular management of these type of cases of abruptio placenta. So I think it was nicely discussed by the previous panelist also, and this is what I wanted to add to the statement. Thank you, madam.
Dr. Manju Puri, madam, would you like to add anything else?
I think well discussed, and what is important is that anticipation is what is important, and one should have a very high index of suspicion. So that means whenever we have these kind of patients, we have to serially do the PT, PTTK, and then decide on, have SOPs so that we can make sure that the components are replaced as and when desirable. And treatment of the trigger is most important. So I think you've already highlighted, Dr. Pushpa, that here we will not delay. So we have to remove the trigger, and the trigger is here would be you have to terminate the pregnancy, and that is how it is. And with the preparedness, with adequate amount of components. Thank you.
At tertiary care center like medical colleges, we are quite comfortable dealing with such patients. But Absolutely. It must be very difficult in the private setups with small nursing homes,
particularly
because this
nursing homes,
complications, they might come unexpectedly. Yeah. So maybe this patient was rightly referred to medical college. Yes. He was treated by a private practitioner initially, but when it was thought that her blood pressure was rising, then it is always better to shift the patient to tertiary
Absolutely.
care center.
Absolutely. So
that's why anticipation of danger has to be there in our mind. Always there should be anticipation of danger. Yeah.
So the take home is that we should refer the patient well in time before this thing happened, because we don't get blood products in private setup.
True.
Dr. Geetha, you have to correlate with the clinical and laboratory investigations, which is a difficult thing always.
Dr. Geetha, would you suggest any other therapy apart from transfusion of blood and blood products?
Well, there is a role of heparin, which limits microvascular clotting, but we cannot use heparin in the case of bleeding patients in DIC. And antithrombin 3 also, it's under study. Recombinant human activated protein C also we can give, but everything is on study only. We don't have proper evidence.
A word, ma'am, because we have to investigate. That investigative protocol is also not available each and everywhere. And also the component replacement, also the availability of various products also.
Availability, cost, everything is important.
Yes, but this was just to suggest that there are some alternative therapies also available. We'll move on to second case. Any panelists would like to add to this case? We'll go ahead with the second case.
One point regarding the first case, there is always a dilemma that in a patient with DIC, we are in which stage of DIC. So sometimes it has to be decided whether we should give heparin or we should not give heparin, and we should embark on giving cryoprecipitate and antifibrinolytic agent like tranexamic acid. So whenever ma'am correctly said in the previously that whenever there is bleeding, we cannot give heparin, but whenever there is ongoing bleeding, so most likely that is because of enhanced fibrinolytic DIC. And if that is a case of enhanced fibrinolytic DIC, we should embark on only with cryoprecipitate or FFP and tranexamic acid. That is the scope of giving. And overall, it has to be a multi-speciality treatment, and we should involve physician, hematologist, and ICU, ITU specialist, so that they can add upon what we are thinking about the patient. Thank you, ma'am.
Sanjib sir, just a second, Sanjib sir. Nishan bhai, there is some disturbance from some other screen. Can you just locate and let us know where from which Nishan bhai? Yeah. I think it's taken care of. Yeah.
Yes,
thank you so much. Yeah. Just do try to locate the disturbance, and if you can point out. Thank you so much.
Yes.
Okay. So sorry, ma'am. Yeah.
A small word suggestion is, because though we refer to the teamwork, the physicians, hematologists, and everyone, the thing is they rely upon the investigations. These investigations, the simple investigations, what we are doing is PT, APTT, and fibrinogen, they are available. But when you want to replace the component therapy, because in a way, developed places, they are going for the concentrated fibrinogen and all. The availability and repetition of the investigations to all the places has to be done.
Can I add a point, Dr. Pushpa?
Yes, ma'am.
Yeah. So basically at our place, we have thromboelastography, which is a very useful point of care investigation.
Yes.
So basically it is with the whole blood that we run it. And within 2 minutes, we would quickly come to know as to which component is to be given. So it is that whole blood will have a graph, which will look at the kinetics of clot formation, its strength and dissolution. So, by the shape of the curve, and there are different timings which we calculate. So we and our anesthetists are able to know whether this patient needs to be given platelets or she's to be given Tranexa, when we see antifibrinolytic activity is more, or the patient needs, more of fibrinogen, or the patient needs a combination of all the clotting factors. So we are actually rationalizing our supplementation or replacement of components based on tech. So I think it is a very good point of care tool.
Yes, madam. Point of care and thromboelastography, they're the things that can give rise to the component selection.
Yes. So all departments which are managing critical obstetric patients must have a tech machine also.
Yes.
Doable thing.
But that is not available everywhere.
Actually, that is positive of those availability of investigations. We'll go ahead with the second case.
Yes.
Vaishali Wagmare, primary gravida at 35 weeks, was admitted through antenatal OPD as her uterine height was 4 to 5 weeks less for a period of gestation. She complained of brownish dirty discharge per vagina since 2 days. She didn't attend any OPD for last 4 weeks because she was running 8 months of gestation. Hence, traveling was not allowed by her relatives. This is a common practice in many places of our country. And she was not sure about the feeling of fetal movements. On examination, general condition was fair. She was afebrile, pulse was 84, BP was 140/90, pallor was 1+. There was no ictus, edema. There was no edema feet. Systemic examination did not reveal anything abnormal. On abdominal examination, uterus was 30 weeks, cephalic presentation, fetal movements and fetal heart sounds were absent. On PV examination, cervix was soft, 1 centimeter dilated, 25% effaced. Membranes were flat and brownish dirty discharge was present. On investigations, the hemoglobin was 9.8. Total count was 11,000. Platelets were 3 lakhs. Rest antenatal investigations were normal. Coagulation profile was deranged. USG was carried out. Before this, I would like to ask Dr. Indranil, what causes DIC and coagulopathy in cases of retained dead products of conception or dead fetus in utero?
Yes, madam. So very unfortunate
situation.
Yeah. We as obstetrician, if we hear a case of IUFD, we really feel sad. Very unfortunate situation for the woman. Coming back to the question, when the dead fetus is actually retained for a longer time in the uterus, like if there is IUFD, the problem what happens is it releases the thromboplastin, that is the tissue factor, which are liberated into the bloodstream. So this, what happens? This creates a widespread microcoagulation by activating the various factors of the intrinsic and the extrinsic pathway. Thus, using up all the factors, that is consumptive coagulopathy, resulting in depletion of the clotting factors. Now, the longer we wait in an IUFD case, the longer the patient has waited, the longer she has not understood that maybe the fetal movement is not there. The longer time, the difficult it becomes to treat that patient. Now, obviously, these sort of patients require special care and fast thinking on the part of the clinician. So if we want to manage, suppose we want to move further into the case, I think the first thing is how to deliver this patient in a proper way. So before the delivery, we have to do all the proper analysis of the lab investigation, the PT-INR, the D-dimer, all these test investigations. And if we find that she has some time, or maybe she has gone into minimal sort of labor, we always have to try for a normal delivery for an IOD patient. That is the first preference. Only if there is absolute indication or absolute problem, or wherein we have to deliver the patient fast, maybe she is having some additional problem, then only we have to go for operative. But it always has to be normal delivery for these sort of patients. So going back to you, madam.
Okay. Dr. Manju Puri, madam.
Yeah.
Would you like to add anything?
Yes. So basically, in this case, I'm a little skeptical about a platelet count of 3 lakhs and coagulation profile deranged. Because in case we are thinking it is consumptive coagulopathy, then the platelet count is used. Because, then it is a combination. So I guess in these kind of patients, when the platelet count is high, one needs to rule out infection as well, because infection can give rise to thrombocytosis, right? Or else I would reconfirm the coagulation profile. Sometimes, people tend to take it in a vial which already has some anticoagulants or something. So I have to say one has to always think and correlate all the findings together to reach a diagnosis. And then, of course, in this patient, one would like to give fresh frozen plasma in case the coagulation profile is deranged. She would not need any platelets, but we'll keep it ready because the platelet count is normal, and then induce the patient and deliver her. So that is what is the thing. And one more point, which is a very practical point, is that one must always remember that platelets are always stored at 21 to 24 degrees centigrade. So they are not to be kept in fridge. If you keep the platelets in refrigerator, they are of no good. And that is what is a very, very important thing. We have seen people the platelets and keeping them in the refrigerator, so that they have to be kept on agitator, and they are effective only for 3 to 5 days. So these are the things which are to be kept in mind, whereas fresh frozen plasma is kept at minus 25 degree centigrade, and it has to be thawed and then used within the next 6 to 8 hours. So I think these are very, very important things which one must keep in mind while we are managing patients of DIC. Thank you so much.
Yes,
so platelet, we
needed an expert.
The platelet are less than 50,000.
Very nicely said.
We needed an expert to point out this discrepancy about the platelet count and the range.
Very nicely said.
Thank you, madam.
Thank you.
We'll go ahead with the third case. Bilkis Bano, Gravida 4, Para 3, Living 3 with diagnosed major degree placenta previa, was admitted at 36 weeks of pregnancy with antepartum hemorrhage. There was history of bleeding PV for last 2 hours when she was admitted in labor ward. On examination, her general condition was not satisfactory. Her pulse rate was 132 per minute, blood pressure was 90/60, and shock index was 1.4. Systemic examination was normal. Uterus was 36 weeks, relaxed. There was breech presentations. FHS were present and they were regular. PV was, of course, not done, and she was bleeding profusely. So, Dr. Poonam, how to manage this case?
Majorly, this patient is having placenta previa, and she is bleeding. And in 2 hours only, you can see her parameters are falling. Her BP has gone to 90/60, pulse rate has increased to more than 130, and her shock index is coming out to be 1.4. 1.4 shock index would say that she has bled hugely, and it is said that if the shock index is touching 1.4, then most of the times the mortality even goes so high, it's 40% in these patients. Normally the shock index should be 0.5 to 0.7. We calculated bedside as we examine the patient. It is done by heart rate divided by systolic blood pressure. So seeing that she will be needing a massive kind of blood transfusion, and so we need large bore needle, IV lines to be put immediately, and then immediately we need to give plasma expanders before we get the blood. And then the massive blood transfusion has to be given to this patient, and that has to be given in a very right manner. Otherwise, we'll be facing the complications of this blood transfusion. So most of the times we give 1-1-1. That is one part, if we are giving whole blood, 1 part plasma, and 1 part platelets we give. So that way we go with these patients. And massive blood transfusion, we say when we need to give more than 10 units. And I think probably patient with a shock index of 1.4 will need almost 2 dozen of bottles to save her. That is, that means that we have replaced in 24 hours, her whole blood has been replaced by what you have transfused.
So
immediately delivery has to be done, that we need to see. This patient will obviously need LSCS because of the placenta previa, and breech presentation is not important in this. Important is placenta previa. So we need to do immediate LSCS, control her bleeding from the operative site, and then give uterotonics and all to control the bleeding, and then give massive blood transfusion. That is the whole.
The problem was this patient continued to bleed per vagina, as uterus failed to contract efficiently initially. With uterotonics, uterus contracted, but bleeding continued.
Bleeding continued. So she had PPH.
Dr. Soumini, what is the cause of continued bleeding PV in such case?
Madam, this is a case of peripartum hemorrhage. Both APH history and postpartum hemorrhage is there. But if it could be, it is not a case of abruptio placenta to inside the placenta-decidual separation and inside the DIC as such. But still, any case of uterine atony can also be continued in case of this particular case. And the conception of clotting factors as such is more in case of abruption incited blood loss, but any blood loss associated with hypoxia and hypothermia as such can incite the coagulation defect. So this patient could have been resuscitated better to avoid the PPH, but still the consumption coagulopathy has occurred in the earlier stage, which then transferred to dilutional coagulopathy. A massive blood PPH is associated with relative massive loss of procoagulants from the hemorrhage. And this could have been due to the disproportional dilatation, replacement of the blood loss by crystalloids and colloids, which leads to dilution of coagulation factors and platelets. So the component therapy has to be, because as was point of care and thromboelastography, if any investigations are there available, what is the component that was lost could have been replaced to avoid this postpartum hemorrhage being continued, which is not responsive to your normal uterotonics and all. And because very rarely PPH is per se can incite, unless it is a massive PPH inside the ovidic.
Dr. Sanjib, Dr. Shakuntala, do you have any inputs?
Yes, ma'am. Basically, this kind of patient, when she is bleeding profusely and she is on the verge of, falling into DIC or like that. So we need to treat this patient as a whole holistically. We need to maintain blood pressure. We need to maintain temperature of the patient, because hypothermia is again can cause further coagulopathy. We need to maintain the saturation as well. And we need to see whether the urine output is good enough. The hydration is good enough. And whenever we are giving massive blood transfusion, we also need to think about whether we should give calcium gluconate, whether it is causing hyperkalemia, needing some management to reduce hyperkalemia in the form of dextrose insulin. And obviously, outside this component therapy, we need to send all the samples as early as possible. At least 4 investigation has to be sent, like P-time APTT and platelet count, fibrinogen level, and fibrinogen degradation product. So these are the basic minimum, and whenever the opportunity is there, we should send the sample as early as possible, and we should do the requisition, the component requisition, and we should actually transfuse the component as early as possible before any suppose there is a need of surgical intervention in a case of postpartum hemorrhage and patient is getting unstable, then we need to correct as much as possible, not always possible to arrange all those blood components beforehand, but at least if we can manage, and if the things are available, then we should correct the coagulopathy first, and then we should embark on surgical aspects. Obviously, that will depend upon the scenario. So that is what I want to say, ma'am. Thank you.
So thank you, madam. Actually, these are potential life-threatening situations. So whenever we come across such cases, it is very important that a detailed counseling of the patient's attendant is to be done and a proper consent is to be taken, because the morbidity and mortality in such cases is of a very, very high percentage. If you can manage it in your setup, fair enough. If you cannot manage it, you should have facility of prompt transportation to a higher center. And you should not hesitate in telling this to the attendants that whether you will be able to manage it here or not. These are two very important points I wanted to bring it to everybody's the August gatherings knowledge. It is very important that a proper consent taking at every step. We should keep on informing and updating the attendants about the condition of the patient. The underlying condition is to be diagnosed and to be promptly treated. Whatever conditions are coming up, if the shock is there, that has to be corrected. If there is any underlying condition which can be corrected, it should be taken care of. So apart from the treatment part that everybody has covered so beautifully, these are the things which I wanted to bring to your knowledge, to your kind attention, madam.
Actually, these patients will then need
disciplinary
specialty care, because
absolutely
there is acute lung injury will happen, then acute kidney shutdown will happen.
And we should not
counseling is very important from time to time. And of course, documentation also is
especially if the patient is on multiple transfusion regimen. any complication can occur. So consent has to be taken,
right?
Even for the blood transfusion, blood product replacement also.
Absolutely. And do not give any miraculous, prognostic points to the attendants that may land you in trouble, when anything happens.
Any expert comment, Madam Puri?
Yeah. So basically, I think what is most important in this kind of a patient is the actual assessment of the blood which is already lost. So if a stock index is 1.4, the patient is in hypotension, she's already lost 2 liters of blood. That is 30 to 40% of the circulating volume. So 2 liters of blood loss would mean that you have to replace that much of blood. And if we do not replace 2 liters of blood, then it will have to be 6 liters of crystalloids. That is what you must assess. And, for every 1 ml of blood loss, it has to be equal 1 ml of blood, or it has to be, for every ml, you have to have 3 ml of crystalloid. And for every ml, it has to be 2 milliliter of, so 1 ml, 2 ml of colloid is equivalent to 2 ml of colloid, 1 ml of blood is equivalent to 1 ml of blood, and 1 ml of blood loss is equivalent to 3 ml of crystalloid.
Correct.
So it should be the volume of replacement. And now if a patient is already lost 30 to 40% of her blood and you push crystalloids to it, you get further
dilute.
Yeah.
So that is a dilutional coagulopathy the patient
exactly. So it is that dilutional coagulopathy. Plus, I think a very nice point was made that she was already in hypotension. Hypotension, hypoxia, hypothermia. So these three are going to contribute to consumptive coagulopathy. So a mixed picture emerges. So that is why a prompt management and prompt transfusion of blood to these patients becomes important.
Correct.
That should be the, when you receive this kind of a patient from outside, you must remember that we have already lost that precious time, and 2 liters is what we have already lost. So I think that is what is the important point.
Regarding shock index in the non-pregnant condition, 0.5 to 0.7, I think is taken as normal, and 0.7 to 0.9 is taken as normal in pregnancy. So whenever it goes above 1, then obviously there is a good chances of coagulopathy, and when it is 1.4, obviously the chance is very much to fall in trouble. Yeah.
That means the patient is already in stage 3 and stage 4 of her
correct
shock.
She's 50% chances that she's already in irreversible shock.
30 to 40% of her whole circulating blood volume lost, which is a huge loss. So 1 unit, 2 unit bloods are not going to make it. Pack cells are not going to make it.
He requires massive blood transfusion.
Yes, massive blood
and in proper way.
Yes. So that assessment is very important. Red flag.
So prompt availability of blood in the center is very, very important at that time. That is exactly what I wanted to bring to attention. That is, we have to have all the factors available. And if the treatment facility is not available in our center, it is very important, without wasting much of the time, the patient should be transported to the center where all these facilities are available.
Dr. Manju, is Novo 7 available?
Yes, we have. It is available. We have tried it.
How was the result?
3 times. It is very costly. But we were not able to save our patients because they were patients of amniotic fluid nepotism. But it has a role. But it is important that we have a platelet count of at least 50,000, and you have, INR also. There should be adequate circulating coagulation factors and platelets for it to act. So that is very important. But we have used it, but we have not been successful. No success.
Due to paucity of time, we could not cover all the causes.
Yeah.
In case discussion. So DIC is a life-threatening disorder with complex manifestation involving thrombotic as well as bleeding complications. The diagnosis is essentially clinical and supported by laboratory investigations. The mainstay of treatment is to eradicate the primary predisposing cause. I hope we were able to clear some doubts on DIC. Thank you, Dr. Komal, for allowing me to participate in this wonderful webinar. I thank Dr. Manju Puri for being with us as an expert, and I thank all the panelists, learned panelists, for their inputs.
Thank you, madam.
Thank you, madam. Wonderful conducted.
Thank you all our co-panelists for
Really,
this
really
wonderful
enjoyed
interaction
it.
today.
Thank you very much. Thank you.
Thank you, moderators. Thank you,
Komal
Dr. Komal.
Komalji, thank you.
Thank you so much.
Thank you, Dr. Komal, and best wishes.
Thank you.
Thank
I was
Thank
really
you, Dr. Manju Puri. Thank you, Dr. Komal. We'll see you as a Vice President soon.
Thank you so much.
Yes,
Really,
Dr. Komal, wish you all the best for
yes,
your
honored
future
and
endeavors.
obliged. And it was an excellent panel, and I was really good messages and the points which everybody, each one of you have brought about, the practical points, they are so good. And I really liked the way Dr. Manju Puri has sum up every aspect, the how to go about and how to go in a systematic way. That is very important, because sometimes when we have this patient of DIC, we really feel that so much is already happened and how to come up out of it, that is the dilemma. And it is really very resolved. Everybody has contributed so well to the panel. Complete justice made by each one of you. Thank you, Dr. Pushpa, Dr. Sanjib, Dr. Soumini, Dr. Geetha, Dr. Indranil Dutta, Dr. Shakuntala Kumar, Dr. Poonam. I think you all are really great points and great inputs given today. And Dr. Pousali is here. She can wind up and give the vote of thanks.
All the very best, Dr. Komal.
Thank you, Dr. Shakuntala.
All the best, madam.
Thank you.
All the best, madam. All the best.
Thank you so much, Komal ma'am. Thank you. It was a wonderful webinar. We had 2 excellent sessions. Thank you to Komal ma'am for organizing this as always and guiding us so well. And thank you, Niranjan sir. Thank you to the speakers and chairpersons of the first 2 sessions. To our guest of honor and to our chief guest. Thank you to our moderator for this excellent panel on DIC and to all our expert and all the panelists. And thank you to my co-coordinator today, Dr. Munjal Pandya. And thank you again to Shield Healthcare, Mr. Nishant and Ms. Chitra for organizing and taking care of the logistics of this webinar. And last but not the least, I would like to end this session by saying a goodbye to all of you, and we hope to see you again because this is just the episode D and we have many more episodes to come under the guiding light of our wonderful Komal madam and Niranjan sir. Thank you so much.
Thank you.
Thank you, Pousali.
Thank you, ma'am.
Well.
Thank you.
Thank you.
Thank you.
Thank you, Komal.
Thank you. Even Munjal is here. Thanks, Munjal. Very well done.
Thank you, Munjal, sir.
All of you have a very happy good evening.
Yes. Thank you. Thank you. Bye.
Bye, madam.
Bye,
everyone.
Bye, ma'am.